A lower standard of living is a choice, and this week America kept choosing it. Measles was confirmed this week in Allegheny County, Pennsylvania, the area in which I practice. And remember, each measles case costs around $60,000 that could be spent on something else. In Washington, the president issued a vaccine executive order and a new request for information to codify disinformation and throttle the vaccine ecosystem. But none of this is inevitable. All of it is logically following from choices. So I'm going to start with measles, and I would say that we're watching endemicity happen in real time. As I said earlier, measles was confirmed in Allegheny County, Pennsylvania, which is the home of Pittsburgh and my home. This was an unvaccinated patient cared for at Children's Hospital of Pittsburgh. Not coincidentally, it lands at the same time the CDC released school vaccination data showing non-medical exemptions that are up by 18%, and national MMR coverage is below the herd immunity threshold. Lancaster County in Pennsylvania is now the #2 measles county in the United States. And the outbreak there, don't be fooled, it's not just in the Amish community, it's in the general population. Going back to the Pittsburgh patient, this patient came from outside Allegheny County and had, it seems like, 2 emergency department visits before diagnosis. So what happened on that first visit? That's an important question because clinicians need to be alert to signs and symptoms that might be consistent with measles. They might not have seen measles in their career. They might not think something is consistent with measles. It has to be now something on everyone's radar because the population has chosen to bring measles back. And this is going to be the norm as we see this virus reestablish endemicity. There was a letter to the editor in the Pittsburgh Post-Gazette from a physician in his 80s, a retired surgeon named Dr. Franz. And in that letter, he talks about the benefits of vaccines, but there's also a line there about when he was a child seeing red placards on houses for quarantine and isolation related to measles cases. That's increasingly going to become common. And it also kind of blows up this idea that our ancestors never thought measles was anything. They clearly did. That's why there were those red placards. That's why they invested time and effort to develop measles vaccines so that we, their descendants, would have a better standard of living than they did. And that's what's being eroded. We have 250,000 kindergartners about to or starting school right now without measles protection in a banner year for this virus. So when you look and see, oh, the numbers might be very small, like 0.1% drop, so long as it's below 95%, the virus is going to take advantage of it. And a 0.1% drop is something that the virus will be able to capitalize on. The other point is when you're looking at state numbers about vaccinations, state aggregates are going to hide hotspots. So if you look, for example, at Florida, it might look okay, but then you look at Escambia County, where Pensacola is, it's 87.3% in terms of kindergarten coverage. Michigan, 90.9%. In my home county of Allegheny County, 60 schools below the threshold. And in Pennsylvania, 2/3 of charter schools are letting people in without actually complying with vaccine entry requirements. And charter schools are going to be a hotbed for measles, I suspect, if the virus finds its way into one. It's going to have a lot of people to infect. South Dakota already passed the 2025 case count in 2026. This is all going to be what we hear about going forward as the U.S. marches towards its inevitable loss of measles elimination status. And the list of states and the list of counties, it's going to become kind of tedious to keep track of, but I think right now they're good examples of how this is in everyone's network. The other point is that there are hospitalizations occurring. Pennsylvania has 50+ measles hospitalizations, which I think translates to around a 17% hospitalization rate. And this is something that annoys me. People ask, oh, how many deaths have there been from measles in 2026 in the United States? The answer is 0, as if hospitalizations and preventable hospitalizations at that are not a valid outcome to measure. If hospitals are stressed because of capacity concerns on a day-to-day basis, this adds to that. And why have a child hospitalized if you can avoid that with the safe and effective vaccines? None of these patients that are getting hospitalized need to be there, but for people's choices. Sometimes, however, these outbreaks do kind of yield bright spots. So South Carolina was one state where coverage went from 91.2 to 93.4%. If you remember, South Carolina had a major measles outbreak. And I think risk perception, risk calculation changes when the threat becomes closer. We'll have to see where this ends up. There are states that have really low measles vaccination rates, like Idaho, Wisconsin, Minnesota, Utah, Arizona. We'll see what happens to their rates. I think some people are going to be rational and take protection and protect their children. Others may not, because they're wedded to this idea that the anti-vaccine movement implanted in them. Another thing I wanted to mention is that when we see heavy transmission, and we're going to see heavy transmission, there are going to be vaccinated individuals who do get infected. The vaccine is very, very efficacious, but it is not 100%. So there are going to be vaccinated individuals eventually that get infected, and maybe even some that transmit the virus. We've always known this, but you're going to see the anti-vaccine movement highlight it whenever it does happen. So keep that in mind. 2 doses are highly protective, but not 100%. And I want to say this now because I know there will be disinformation as we progress into the school year and measles likely accelerates. But the point that I think is an overarching one that's important to keep in mind is that this isn't something hard to fix. And there was an interview with a local pediatrician in the Pittsburgh Tribune Review, Joseph Arakri, who is the chief of pediatrics at Allegheny Health Network, saying the solution is simple. And I've been saying this for a long time as well, that it's vaccination. The solution has been there. It's been there since the 1960s. This is all voluntary. So when you have exemptions, non-medical exemptions up to 18%, coverage falling below 95%, back to school, mixing, seeding, under-vaccinated pockets that exist in every community, that's a formula to get endemic measles. That's the consequence that is basically inevitable. In each of those cases are going to cost $60,000 that could be spent on something productive, but yet it's being spent on something where it's basically spent on trying to deal with this lower standard of living that people have chosen for themselves. I want to now move to a broader story about the anti-vaccine movement. That's the dismantling of vaccine policy. So this past week we saw the vaccine executive order. The consequences continue to reverberate. Thankfully, around 210 organizations signed a letter opposing it. This executive order by the president, basically, as I've said, is a codifying of anti-vaccine disinformation and a huge win for the anti-vaccine movement and for RFK Jr. Health and Human Services has also published kind of this request for information from the general public to think about new vaccine categories like recommended with qualification or different ways to do clinical trials. This is RFK Jr. and his cronies dismantling, disrupting, basically obliterating the vaccine policy ecosystem. This is calculated. He knows how to do it and is very effective at doing it. At the same time, you have the newly installed CDC director, Dr. Schwartz, at a CDC town hall saying she's going to speak truth to power. Don't be mistaken, she's only going to do it privately. And she also says that she's very comfortable talking to RFK Jr. No one should be comfortable talking to someone like him. This is a person who has an anti-human ideology. No one should feel comfortable talking to someone who wants to basically make civilization go in reverse, who would like to see more measles cases, more chickenpox cases, who would like to see mRNA vaccine technology end. No one should feel comfortable being in the same room as him. The ACIP, which RFK Jr. has reconstituted in his own image, has not met. And again, this is another aspect of vaccine policy, which leaves flu season guidance, COVID vaccine guidance kind of in the air in limbo. But thankfully, the professional societies are coming in to kind of fill that gap in a much better way than an ACIP controlled by RFK Jr. could do. So when you think back to what this executive order did, it basically was political pandering with a presidential seal. States are thankfully ignoring the federal government on this issue, most of them. I'd like to see all 50 do it. And this request for information is just to try and sow confusion by making different vaccine categories, saying, oh, this one is recommended, this one in certain groups, this one with a qualification. All that does is make people unable to actually discern what they need to protect themselves against and where the actual recommendation is backed by science versus not. A lot of this is it's in the headlines, it's inside baseball, but the overarching thing you need to know is what they're trying to do here is dismantle the vaccine ecosystem. And I keep coming back to that point. That's what RFK Jr. has telegraphed for decades, and that's exactly what he's doing real time, and you're all seeing it. One of the things that the executive order asks for is to break up the measles, mumps, rubella vaccine, the MMR vaccine, into its constituent shots. And I think even just bringing this up, saying that parents should have a choice between the monovalent vaccines and the combination vaccine, that kind of gives you validity. There's a reason to do that. There is no reason to do that. The MMR was put together for a reason, to actually improve vaccine coverage, to make it easier to give those vaccines, to decrease the number of shots and administration costs from from 3 down to 1. And Jesse Steer talks about that in SIDRAP in an op-ed, talking about the fact that when you're offering these parents this choice, you're saying that there is some valid reason, and there is no scientific reason to separate these. Monovalent vaccines mean more measles, mumps, and rubella. That's what they mean. And remember, the economics aren't very good, and I'm getting all kinds of pushback on social media saying, oh, now that's 3 visits, that's more money, or now they've got 3 vaccines instead of 1. That's not the case. These are not profitable things. Companies don't want to do this. And the International Monetary Fund, the IMF, noted that even successful vaccines are barely profitable. Biotech and pharma don't like vaccines. They don't make money the way a cancer drug does or a cholesterol drug does. And now you have the government trying to make this kind of dictate to make unprofitable products. It's going to drive more firms out of the vaccine business, and they know it, and we will all be worse off for it. I want to mention something about the CDC director, because the CDC director, in my mind, exists to stand up for science and medicine publicly, to the American public, just like Dr. Menarez did. When Dr. Schwartz says that she wore a uniform, so she wants to only voice disagreements privately, that's a cop-out. She's basically telling you, I know I'm going to disagree, but I'm still going to do it because I wore a uniform at one time and I just like to follow orders. And moreover, you can't be comfortable in a room with someone who denies germ theory and push cod liver oil during a measles outbreak. Why would you be comfortable in that kind of a room? Why would you be comfortable talking to someone like that? If you are, something is wrong with you.
They have treated most of the patients, actually, over 108 patients in the last 48 hours, and they're getting very, very good results. They report from cod liver oil, which has high concentrations of vitamin A and vitamin D.
ACIP has not met. I don't think it's a valid institution, but unfortunately, some of our vaccine policy is tied to ACIP recommendation. So we have the FDA picking flu strains, picking COVID strains. We have the American Academy of Pediatrics, the IDSA, the American Academy of Family Physicians, all issuing recommendations that clinicians, insurers, and pharmacies should follow. But I don't know how this policy thing gets fixed because of the way the Affordable Care Act links insurance coverage to the ACIP recommendation. I also wanted to mention Senator Cassidy. So just to so you recall, Senator Cassidy is a powerful senator, a physician who helped to advance RFK Jr.'s nomination. And in an interview, he said that confirming RFK was the best decision he could make in that situation. That's a massive evasion. It was a politically expedient decision. Everyone knows that RFK Jr.'s promises were lies. So I don't know why he's trying to save face now. He should just own it and say, the politics are more important to me than my profession. I wanted to stand with Trump and RFK Jr. I did not want to stand with Pasteur and Jenner. That's what he should say. Moving on to the DRC Ebola outbreak. This is the deadliest Ebola outbreak on record in terms of the cadence and momentum. The deadliest outbreak, obviously, that the DRC has had. And there were times where they were saying a death was occurring every 28 minutes. And we have 6 provinces affected. A third of these deaths are in children. Ituri is the hardest hit province, but we're seeing cases rising faster in other provinces. The Merck Zaire vaccine, which targets a different species of Ebola, that's being used. Gavi is funding this, and they're deploying it. So we'll see how that all turns out. One of the things I wanted to mention was the fact that the case fatality ratio, so if you got Ebola, what's your chances of dying? It's more than doubled, from 20% to 46%. So there are more people dying from Ebola than at the start. And I think that's a signature of a failing response, not just a growing outbreak. And some people might say, oh, this is case ascertainment. They're only getting the sicker patients. I don't think that's the case. I think it's that there's a failure to render care, a failure to be able to get people to Ebola treatment units to be able to do things like electrolyte replacement, fever control, IV fluids. That's what's, I think, driving that mortality rate to go higher. More people are dying in the field, in the community, than in Ebola treatment units. And I think, obviously, in the community-based care model, where people are being treated at their home, not only are there infection control risks, they're unlikely to be able to actually get supportive medical care. And I think that's what's driving that higher case fatality ratio. And as the WHO says, Ebola is winning. Why is it winning? Contact tracing has basically collapsed. Tracers are working 15-hour days with uncertain pay, according to the Associated Press. There's community distrust that is massive. Some of it is perceived by profiteering of aid money, which is why it's so important to be very transparent about aid money and where it's going and making sure that you do root out corruption. I think the key thing here is going to be anthropology leading to community ownership of this outbreak. And I think this is going to burn a year or maybe more. And there are these optimistic forecasts that maybe we can get control of this in 3 months. I don't think that that's realistic. The Merck Ebola vaccine is targeted against the Zaire strain, and it is highly effective. There has been this kind of idea that there might be some cross protection against the Bundibugyo species. So 70,000 doses are being mobilized. 50,000 are going to go to frontline workers, 20,000 to a clinical trial to see if this actually works. CEPI is funding a lot of the supporting science to try and understand the cross protection and actually how robust it is. But I think this is really the first test of repurposing that vaccine across Ebola species. One of the interesting things I read had to do with motorbike drivers. They're basically the makeshift ambulances that pick up patients, transport them, and they've got enormous untapped epidemiological data, where these patients were collected, where they were dropped. And there is an effort now to engage motorbike drivers to try to harness that information, which might help fill some of the contact tracing gaps. But it is also really, as all this doom and gloom about Ebola, I want to keep perspective here that this is still a virus that is very constrained in terms of its ability to spread. It spreads via blood and body fluid. I don't believe that even with the severity criteria that you see going on here, that this has pandemic potential. I don't believe pandemics can be caused by something that cannot spread through the air. The next thing I wanted to mention was a little bit about how to talk about vaccines to people. And one of the things that prompted this was there was a letter to the editor in the Washington Post by Stanley Plotkin. So if people know, Stanley Plotkin is the grandfather of vaccines. He literally wrote the textbook on vaccines. And he published this letter where he made kind of a familiar claim about vaccines relying on an idea that people are their brother's keeper. Get vaccinated for other people. I very, very respectfully disagree with the framing, because when you look at that for multiple reasons, I think it fails. And even research that's coming out now keeps converging on an alternative. For example, a study in Vaccine found older adults respond to vaccine messages when vaccination is framed as preserving their independence, their freedom from shingles, their freedom from RSV. That works. That's not being your brother's keeper, that's being your own keeper. And there was a Rush University study showing that anti-vaccine sentiment has different drivers in different groups. It's not monolithic. How do I argue for vaccines? Vaccines are a technology that lets an individual live in a world full of infectious disease threats. They free you from worry about measles, from influenza landing you in the hospital, from chickenpox, from tetanus, from whooping cough. They may not completely eliminate that risk, but they make it much, much more manageable. As such, they're really increasing your freedom of action. They're not restricting you. They're actually freeing you from those microbial threats. The anti-vaccine movement gets it actually backwards. And I think that the brother's keeper argument, why it fails, is that they're selling it on altruism, and they're underselling or completely evading the individual benefit. And that's not reliably going to move people. And some people simply don't believe themselves to be their brother's keeper, including me. The case for vaccines doesn't depend on altruism. It depends on individualism. People taking control of their life, trying to protect themselves and their children from microbial threats so that they can live flourishing lives. That's how I think vaccines should be framed, because that's how all technology works, that it improves individual human lives. So think about saying vaccines protect your independence to an elderly person. They protect you from having heart attacks that are a result of a bad flu case, or dementia, as we're hearing with the shingles vaccine. And that will lead to increased acceptance. That's the individual benefit thesis, and it has data behind it. Remember also that the anti-vaccine movement's top is monolithic. They may have their own philosophical ideology, and they've written about that, but the drivers are going to differ by age and demographic group. There's not one-size-fits-all responses. Some people may think a vaccine doesn't work. Some people might think it's too expensive. Some people might believe in a conspiracy about the vaccine. It's all going to be different. So you have to meet each community's actual questions when you're thinking through how to respond to individuals who have questions about vaccines. And remember, the opponent is very good at packaging disinformation to make it look reasonable. And that was a quote or a paraphrase of something that the vaccine policy researcher Dorit Rice said. Think about the MMR separation push. That might seem reasonable to the general public. They know how to package that disinformation in a way that makes it less irrational sounding to someone. Moving on now to the foodborne outbreak season. So there's lots of things going on with cyclospora and salmonella. So the jalapeno link salmonella outbreak is now at 431 cases with 57 hospitalizations. They've been interviewing a lot of people and figuring out that jalapenos related to Chipotle, Qdoba, that may be the link, and I'll get to that in a second. The cyclospora, biggest year on record, over 15,000 confirmed cases. There's still more processing, like I think over 10,000 more cases needing to be processed, and you're starting to see lawsuits land relating to the cyclospora outbreak. So a couple of things I want to talk about here. Back to the salmonella outbreak. The jalapeno investigation is basically textbook shoe leather epidemiology. This is how you figure out the cause of an outbreak. You ask people what they ate. When they did, 91% named Qdoba, named Chipotle. That's how they zeroed in on it. So that's why it's really important to support core public health. They need staff to do that, to interview 200 plus people and to be able to zero in on what they have in common. There is going to be a lot of medical legal ramifications from this year of foodborne outbreaks, namely with cyclospora. So Taylor Farms and Taco Bell faced a lawsuit in Meadville, Pennsylvania. One of the things I would say is actually make sure that people had cyclospora, because there are people that are going to get into this churn of lawsuits and plaintiffs' lawyers where they might not even actually have had cyclospora. They might have not had the test done, and they just think they had cyclospora. And I say that from experience because there are people that I tested for cyclospora that had enteropathogenic E. coli, for example. And testing is up a lot. So there's lots of people getting tested. So we're seeing more cyclospora. So maybe there's a new baseline of cyclospora because we were missing lots of cases. But in that testing, people are testing for other GI pathogens. So more things might come up. But laboratory confirmation matters medically, epidemiologically, and legally. There was an interesting interview in Time magazine from someone who was a former USDA official. They're asking about lettuce and what it is about lettuce. And he said that the volume of lettuce that's consumed is too much or too high to actually guarantee sterility. And what he was advocating there was for checking for contamination, meaning you go through a lettuce field and you sample and do PCR testing, you do microbiological testing and say, is this relatively free from contamination, rather than trying to focus on completely sterilizing the water that you use, because he said in that article that it was impossible. Some other foodborne things to keep in mind. There is a listeria lunch meat recall. Remember, listeria is a very serious foodborne illness, especially for the immunocompromised, especially for the pregnant. The egg-based salmonella recall is now an FDA class 1. Texas seems to be the hardest hit state. The UK also has its own salmonella outbreak from imported eggs, and someone's already died in that outbreak. There's another outbreak relating to salmonella and alfalfa sprouts with both salmonella and E. coli, 15 states. And there is an outbreak related to granola with moringa powder in it, also contaminated with salmonella. So this is all happening at the same time. There was one avoidable one. There's 21 people sick in Ramona, California, and San Diego County from unpasteurized mayonnaise. Why should you be eating any unpasteurized anything? I just don't know why people continue to do that. Remember, poultry always carries salmonella. So if you're eating some unpasteurized product, there's a high chance that you could get salmonella unless you cook it. So just keep that in mind. There was an article in Inc. magazine, which is a business magazine, talking about the economic consequences. And it made the point that a single contamination event cascades economically, even onto adjacent businesses that were never involved. So it's not something that you should take lightly, or that food companies should take lightly, because they can really be harmed. Their business prospects can be really harmed by these outbreaks. 14 foodborne parasites cause 171 million illnesses. So the burden is not just body counts, it's also about disruption. And that's kind of what the Inc. article talks about as well. Infectious disease resiliency is not just a healthcare issue, it's a business issue. It's a business continuity issue. Think about what's going on with Chipotle, with Taco Bell, with Qdoba right now. This is something that all businesses should take very seriously. The last story I wanted to mention has to do with COVID and the summer wave. So most states are now showing increased activity of COVID, basically all of them. We expect this in August. It's still a very low baseline. It's not as if we have lots of emergency department visits from COVID or hospitalizations. And these summer waves are getting smaller and smaller each year. But in some places, they're actually rivaling the winter wave, which is really paradoxical for a coronavirus, but something to watch, what the summer wave looks like versus the winter wave. So you're going to see stories about COVID, and it's not the same old COVID from 2021, 2022. This is COVID as an endemic virus that has this predictable summer wave. Why do we get this summer wave? There was an interesting article in USA Today interviewing Michael Mina, who is a microbiologist and a big and a COVID subject matter expert. He talks about something that I think a lot of people think, that in August it gets very hot, people go inside, they want to be around air conditioning, that increases viral transmission. I think that's probably the best explanation that we have for it now. We're not seeing the rise of some new variant that's escaping immunity, although immunity is fleeting to COVID just like it is to other coronaviruses in terms of protection from infection. But it is something that we're watching right now, so no doom and gloom about it, but COVID is more prevalent right now than it was last week, and it will probably increase again next week. Some other interesting COVID studies. There was a study looking at Bolivian indigenous tribes that don't have obesity, diabetes, cardiovascular disease, and they rarely got lower respiratory COVID, meaning they might have gotten a runny nose, they might have gotten a sore throat, but they did not get cough, shortness of breath, pneumonia. So that just shows you how comorbidities in many Western countries synergize with COVID to give us the horrendous mortality numbers, the horrendous hospital capacity crush that we had. Comorbidities potentiate the severity of COVID. Lastly, one interesting thing about COVID, I was reading a story and there was somebody like in the Bay Area interviewed in an article, and they were talking about how they looked at their phone and they said, oh, COVID is up and I'm going to take whatever protective actions I think are necessary for me. That's how we want it to be with surveillance, that you can look at your phone the way you look at a weather app and say, oh, COVID is up. I'm going to go visit my immunocompromised grandmother. Maybe I should take precautions. And whatever, and it doesn't mean that everybody has to take the same precautions, but I think the situational awareness is really good. So people know what's circulating in their area, not just COVID, but flu and RSV and norovirus and the whole thing. That's the promise. And it's not a technological problem now. It actually is an implementation problem. So to sum up what I've been talking about for the last half hour or so, think about what actually underlies all of these stories. The measles case diagnosed in Pittsburgh, an ACIP that's non-functional, Congo's Ebola outbreak getting a vaccine trial, even the argument of why we vaccinate at all. None of this is happening because the science is running dry. mRNA platforms, genomic surveillance, even plain leather shoe leather epidemiology, all did exactly what they've been designed to do, what they've been built to do. What's been giving out now is human choice. An exemption form that might be signed, a warning that's muted, an agency that's gone quiet. The mind that eradicated smallpox hasn't gotten any dumber. That's D.A. Henderson's mind and all of his intellectual descendants. And this is the week that I wrote a post about the 10-year anniversary of D.A. Henderson's death. And he, I think, would be disgusted with what's going on. And it's not a mind or an intellectual problem that we have here in terms of do we have the wherewithal to solve or master these infectious disease problems the way DA did? We do. Disinformation has not erased that capacity. What it's doing is talking us out of using it.